continue.
Good morning, everyone. This is Ted Baker, Chief Inspector of Hospitals here at the CQC, and thank you for joining our webinar this morning. This morning, we're going to update you on our transitional regulatory approach and our strategy. So we'll be looking at what we're doing in the immediate future, but also our plans for the longer term future over the next 5 years. During these challenging times, the CQC has been using what we've learned during the COVID pandemic to actually inform our way forward, and I'll be explaining that as we go through and try to explain to you what our approach is going to be and give you the chance to interact with us, ask us some questions, and I hope as well get involved in feeding back on our strategy going forward. So thank you again for joining me. I'm joined with some colleagues from the CQC. And Steph, do we have the slides up on the screen? Oh yeah, that's great. Thank you very much for that. So I'll be talking to some slides we'll go through as we go through the seminar today. I'm joined by some colleagues from the CQC. You see their names there. They may well answer your questions on the chat, or they may well step in to help me with some of the questions when we get to the question and answer session. So thank you for colleagues from the CQC from joining me. We can't hear your voices on this session, but you can feedback on the Q&A section of the Teams chat, so please do feedback and ask questions. I'll stop at a couple of points during the webinar to make sure there's an opportunity to answer some of your questions. We may not be able to answer all of them, but all of them we'll take note of, and if necessary, we'll feed back to you later. Okay, Steph, can we have the next slide, please? So what are we going to cover today? Well, we've got an hour and we'll finish on time. I will only be able to cover some of the headlines about our transitional approach and strategy. The detail is on the website, and we'll give you those links at the end of the webinar if you need to follow up following the discussion. But we'll be talking a bit about the timeline, our transitional approach, as I say, our future strategy, and the way forward for the CQC. And as I say at the end, there'll be an opportunity for us to explain to you how you can get further involved. Next slide, please, Steph. Okay, so a lot is changing at the moment, but one thing that is not changing is our underlying purpose as a regulator. We still have the fundamental standards, we still have the regulations, and we're not anticipating that they will change. And so our purpose as a regulator stays the same. We're going to change the way we regulate in many ways, and I'll explain that as we go through, but our underlying purpose stays the same. Our purpose is to make sure that services provide people with safe, effective, compassionate, high quality care, and to encourage services to improve. And that last element, to improve, is an important part of our strategy going forward. Next slide, please. So why are we changing? Well, I suspect I don't need to explain this to you. You are out there working in the services that we regulate, and the services are changing. They're changing in response to new technology, new approaches, new understanding of how to better provide services, but also it's the changing needs of the population we serve. So as the services change, we need to change. We recognise that. But also, of course, we as the regulator have learnt a lot over the last few years from our regulation. And we recognise that the regulation that has served us well, perhaps for the last few years, needs to change so it can become the kind of regulation we want in the future. This is driving our purpose, and particularly that element of how to encourage services to improve as a core element of what we're doing. So we need to learn from our past, from the feedback we've had from you, and from the experiences we've had over regulating over the last few years. And of course, technology is changing and we need to adapt and respond to that. So there are lots of reasons why we need to change as a regulator. And going forward, as I say, we are changing, but our purpose stays the same. Next slide, please. So this is a timeline, and I'm not going to go through this in detail, but we're halfway through a change process, if you like, now phase 3 there in the centre of the slide. And it is the transitional approach, which I'll be talking to you about in a moment. As we go through winter, we will be launching our new strategy in January of next year, and there'll be an opportunity for a formal consultation around that strategy in January. But the draft strategy is already being published, so there's an opportunity for informal consultation and feedback now, which is why this is so important. The strategy will then be implemented from May of next year, and that will be the future looking forward for the next 5 years or so for the CQC. But in a sense, we are still learning, because the COVID pandemic has been such a big challenge to all of us. To you, I'm sure it has affected the way you provide services enormously and has created enormous pressures for you. But for us as a CQC, as a regulator, it has been a big challenge. How do we adapt effectively to fulfill our purpose during a pandemic? And what can we learn from that going forward? And I think there'll be a big theme of that as we go through the slides this morning. Next slide, please. So first of all, I'm going to talk about our transitional regulatory approach. And that is the approach we are using now and the approach we'll be using for the next 6 to 8 months or so. And it's a transition between where we are during a pandemic and regulating during a pandemic and where we want to be in terms of our new strategy. That's why we're calling it the transitional approach. And it's transitional because it is a process. We will be learning and it will be developing over those months in response to the changing circumstances externally, but also in response to how we learn from actually applying the process over the next few months. So for us, it is a very much an iterative process going forwards, but will eventually lead to our future regulatory approach, which we'll be implementing in the second half of the next calendar year from summer 2021. Next slide, please. So just to recap, as I said, the COVID pandemic was a big challenge for us, as it was for you. And one of the things we had to do early on in the COVID pandemic is adapt our approach quite rapidly to make sure we're in a different position from our traditional approach, which was very driven by large comprehensive inspections, to an element which is much more driven by monitoring and relationship building, backed up where necessary with inspections, but not driven centrally by inspections. And that initially we called the emergency support framework. That was put together by colleagues at the CQC very rapidly in the spring in response to the pandemic. And we got a lot of very positive feedback from providers about it. And the emergency support framework was a digital platform that allowed us to have structured conversations with providers around the risks they were facing and how they were addressing those risks. So it gave us an opportunity to understand how providers were challenged and how they were addressing those challenges, but also an understanding of the risks in the system. And what we managed to do during the emergency support framework is use a lot of that feedback to make sure providers were getting the support they were needed. And we managed to support providers accessing testing for their staff and patients. We managed to support providers in getting PPE and also providers in exploring how they could improve their infection prevention and control. So to deal with some of the real risks they were facing in the face of the COVID pandemic. But it also allowed us to assess risk and to make decisions whether we as a regulator needed to do any more. The fundamental building block of the success of the emergency support framework was having open and honest conversations with providers. And that is absolutely fundamental going forward to our approach going forward. As we take the transitional regulatory approach and as we build our new strategy, monitoring is going to be central to this, and monitoring has to be built on open, honest relationships with providers. So we as a regulator need to adapt our behaviour to make sure that's true, but also we challenge providers out there to adapt their behaviour to build a new, stronger relationship with us as a regulator going forward. The transitional regulatory approach is what we are using now. It replaced the emergency support framework and built on what we've learned from the emergency support framework. Again, it is built very much on monitoring and a structured relationship with providers, backed up by other regulatory activity when necessary. Next slide, please. An example of what we're doing at the moment, and I won't go into this in great detail, but for those of you working in acute trusts with emergency departments know that they are facing enormous pressures at the moment with COVID on top of the normal winter pressures. And we saw that was going to be a risk going into winter, and we've been working with emergency department clinicians from good and outstanding emergency departments across England over the last few months to bring together the best resource possible for emergency departments to use in addressing the real major challenges they face at the moment and going into winter. And we've called this Patient First. It was published 2 or 3 weeks ago. It was very well received, but Patient First is a resource built on the experience of the best services in dealing with the pressures that emergency departments face, and we want to use that in a constructive and supportive way with providers. And going forward, we'll be focusing on the areas, the 5 areas there that highlighted at the bottom of the slide in terms of Patient First, flow, infection control, reducing ED attendances, staffing and treatment, those areas. And do have a look at this resource if you haven't seen it and it's relevant to you. We'll be focusing on those areas in our structured conversations with acute trusts to make sure they understand the resource, are using it effectively, but also getting the support they need. And it's really important to say this is not just a resource for the emergency department, it is a resource for the whole trust, and it is a resource for the system in which the trust works, because it is very clear that in order to address the problems of emergency departments, everyone needs to work together. And that kind of system collaborative working, again, is a real strong theme going forward in our regulatory approach. Next slide, please, Steph. Okay, so where are we now? As I say, we've combined our existing methodologies. So those are our assessment framework that you know, the CLOEs, the 5 key questions and the CLOEs, with what we've learned from COVID-19 around the emergency support framework. And that has developed into our transitional regulatory approach, which we're using now. Now, we are learning as we go, so our transitional approach is very much a learning exercise for us. We want it to be effective as it is, but we want it to become more effective going forward so that we can mature into the kind of regulator we want to be, that I'll discuss in our strategic themes later on. So that's going on now, and that will continue for the next 6 to 8 months until we roll out our new approach following the consultation on our strategy in January. Next slide, please. There are 2 elements. I can't go into all the details. It's on the website there for you if you want to understand our transitional regulatory approach in more detail. But there are 2 elements to it. Building on the emergency support framework, a strengthened approach to monitoring. This will be using our existing key lines of inquiry. And we'll use different key lines of inquiry to reflect the risk in the system at any particular time. And that will be backed up by inspection activity, but it will be different from the comprehensive inspections that were the main elements of our inspection activity before. These will be targeted, focused inspections. They're targeted and focused because we want to focus on risk, but they're targeted and focused because we want to reduce our impact on the ground during the COVID pandemic. And we recognise that inspections are an extra burden for trusts to bear, and we only want to use them where there is identified risk, because that is what we need to do to fulfill our purpose. But we want to limit the burden of them wherever possible. If we use the transitional monitoring approach effectively, and if we build up a strong relationship with trusts, then that will lessen the need for us to do targeted and focused inspections. But where we identify risk, we will still take that activity. Next slide, please. So the monitoring approach, as I said, it's built on the emergency support framework and our existing key lines of inquiry. In the initial stages, at the moment, we're focusing on safety, access to care and leadership. Leadership, of course, is absolutely key in this, but we're particularly looking at risk in terms of things like infection prevention and control. And as I've mentioned, in emergency departments, for instance, issues related to flow in emergency departments. So we will be focusing on those risks we know the system is facing at the moment. Also, but all the risks that we've identified by other intelligence work we're doing. And I'll come back to that in a moment. We're also reviewing the information we get from other sources. And one of the things we've been doing over the last couple of months is developing what we call provider collaboration reviews. Now, these are reviews that are done virtually. They don't involve any on-site activity. But what we're doing is talking to providers across a system to understand how they are collaborating within the system. The initial work we did was around 11 areas in England, across England, to look at how providers were collaborating around COVID-19. And the results of that were published a month or so ago. Currently, we are working with systems to look at how providers are collaborating around urgent and emergency care. So again, focused on that risk around urgent and emergency care and understanding what drives successful provider collaboration in those areas. Going forward, the next stage, we'll be looking at how providers collaborate around cancer services. And then we'll be looking probably further on about learning disability services. So we want to look at particular areas and look at how providers collaborate in those areas. This, of course, comes back to our strategic theme, focusing on patients and focusing on patients, how patients experience care within systems, not just from individual providers. So it's going to be very important in forming our way forward and builds on the work we did on local system reviews a couple of years ago. We're also piloting other ways of gathering information, both from people using services and from providers. And so we will be piloting, we may be coming to individual providers, suggesting we run a pilot to understand how we can change and adapt our regulated process going forward. Now, coming out of all this, there will be risk assessments which will help us make decisions about any regulatory intervention, such as inspections we need to undertake. But those will always be professionally driven by our professional inspectors. So we're not turning to a system that, if you like, becomes an algorithm driving regulation. There will be a lot better use, we hope, of intelligence, but we want to always keep the professional judgment of inspectors at the actual centre of our regulatory activity. Next slide, please. I think at the moment we are thinking long term about how inspections will play a part in our long-term strategic plans for regulation. We think it's going to be a very different approach. It's going to be much more focused and risk-driven, but also we see monitoring activity being the centre of regulation, and inspection, if you like, being a way of validating what we're learning from monitoring activity, rather than being the driver of the information itself. And COVID-19, because of the pressures it's created, has given us a chance to start moving in that direction. It's tentative for the time being, and let's be clear about this. We will only move as fast as we are confident that we can assess the risks effectively. But during the COVID pandemic, our inspections have been predominantly driven by assessment of risk, and where we think there are concerns about services. Some of that is coming from our monitoring activity. Some of it is coming from other intelligence. And one of the really positive things during the COVID pandemic is we've seen an increase in frontline staff raising concerns with us, and we've seen an increase in patients raising concerns with us. And we think that reflects an improvement in the openness of the system, and we welcome it. And we're very grateful to everyone who does raise concerns directly with us, because that's really helpful in us understanding the risks in the system and making sure we're focused in the right way. What we're moving away from is the frequency-based rules on inspection frequency. And so we won't be going to an inspection just because it's due. We're going to do an inspection because it's necessary. And those inspections will be focused, so they will be limited in their scope, focusing on where we believe the risk is. Next slide, please, Steph. So what about ratings? And I think this is a big question for us, it's a big question for the public, and it's a big question for providers. Now, the focused targeted inspections we're doing at the moment do not naturally generate ratings because they don't look at all 5 key questions and all key lines of inquiry. So in the majority of times when we're doing focused inspections under the transitional methodology, we will be using that to drive regulatory activity rather than using it to drive ratings. Occasionally it may drive changes in ratings, and so I'm not saying there'll be no changes in ratings, but that will not be the main driver behind it. But we need to understand how we are going to keep our ratings up to date. You want our ratings to be up to date, and the public want our ratings to be up to date. So we need to make sure we can do that. And of course, COVID, because of the hiatus it's created in rating inspections, is a concern in that regard. And we will be bringing forward plans to make sure our ratings are up to date as soon as we possibly can. And we want to deliver that as early as possible in 2021 as we can. But those plans will be coming out, I think, in the relatively near future, but they're not yet part of our transitional methodology. Next slide, please, which I think is the question slide, is it not? Okay, so everyone, thank you very much for listening. That's 20 minutes of information for you. I hope it all makes sense. What I'd be keen to understand is, do you have any concerns or questions about the transitional approach? So it's open to you for questions in the Q&A session. We'll try and answer them as best we can. We'll just take 5 to 10 minutes on this, and then we'll move on to discussing our forward-looking strategy. So over to you. Any questions? So Sarah, are you fielding the questions for me?
Yeah, so we've got a few that have come in. One around, I think you touched on that we won't be re-rating, but there's a comment that's had quite a few likes, so probably resonates with a few people, that their relationship owner has told them that their rating can't change without a full comprehensive inspection, but that their intelligence suggests that they've improved in many areas since their last inspection. How do providers then get a chance to demonstrate this and provide assurance to their patient population?
Well, thank you for the question, and thank you for all the likes of the question. I think it's a really important question, and it is really at the forefront of my mind. Of course, we as a regulator have to address risk, but equally we want to demonstrate the improvements that people have worked so hard to deliver. And I think that's really important. So I'm very keen that we develop a way forward that does not require a full comprehensive inspection, because what people have been told is entirely right at the moment. Under our current methodology, ratings require a comprehensive inspection. But it is not realistic to think we can do that during a COVID pandemic. I mean, clearly the risks of that would be to the service and to staff and people using the service would be too great, but also the burden would be too great. But equally, there is a real need for us to demonstrate our ratings are up to date and to demonstrate that improvement you've been talking about there. And we are really focused on how we can drive that forward as soon as possible in the new year, and we will certainly be producing plans for that soon. It means that we may have to start thinking of a different approach to ratings going forward. As I'll talk about in our strategy in a few minutes' time, our vision long term is for a very different approach to ratings. So in a sense, we want to build a bridge between where we are now and our long-term vision. And we're keen to do that in a way that keeps our ratings robust and rigorous and credible, but at the same time enables us to deliver them in a more frequent basis. So we are very much focused on that at the moment, and we'll provide guidance on that as soon as we can. Any more questions, Sarah?
Yep. So one question around, without a frequency rule around inspections and monitoring, this could open a large volume of monitoring checks. How will these be managed to avoid trusts being overwhelmed?
Well, I think it is important that we do have a regular interaction with trusts and other providers. So that means regular phone calls or video calls such as this, occasional visits as well. But we don't want those to be onerous or burdensome. What we're looking for is that relationship to be a supportive relationship. I'll come back to the improvement issue in our strategy in a few minutes' time. So we hope and we want people to welcome that interaction rather than see it as a burden. But of course, for us, it's doing two things. It's one, helping us support trusts and help them find improvement going forward. But also, I hope, give us the good confidence that those trusts are managing their risks well. It's that open, honest discussion that we're really looking for. And those trusts that do this well with us, I think, have got real benefits from it. It is about us understanding the risks through the eyes of the provider and getting confidence that they are managing those risks effectively. That gives us confidence that we as regulators don't have to intervene. I think those providers, and there are still many out there who try and keep the regulator at arm's length as much as possible, are the ones that give us the most concern, because then we do not know if they're facing a risk and we don't know if they're managing risk effectively. So that discussion, that monitoring relationship, is about us gathering data, but also about building a relationship. And I think that's really important.
Thanks, Ted. And then a question on whether the risk model is available for review, as it would be useful for providers to see what CQC deems to be high risk.
Yeah, okay. The questions we'll be asking during the monitoring process are on our website, and we'll give you that link towards the end. So in a sense, we want to be as transparent as possible about understanding what's going on. We're not looking to produce risk assessments. I don't know if those of you who've been around a few years will remember intelligent monitoring, which was something that was rolled out in 2014 for 2 or 3 years. And we produced scores, risk scores for trusts. And people before that may even remember the quality risk profiles that came back before. I remember those as well when I was in a trust. That we don't want to produce risk scores that then become a kind of surrogate rating. We want to see risk as a much more dynamic process from day to day. And those discussions with you will be about risk and about how you see the risk, but also about how we understand the risks. Those discussions will be opportunities for us to share our assessment with you, but for you to share your assessment with us.
Thank you. And then a question how are we ensuring that we don't compromise our role as the independent regulator in providing support?
Well, that's a very key point, and that's been a lot of internal discussion going forward. Our support cannot be telling you what to do. Our support can be helping you find other people who can give you the advice. We're coming in to our strategic themes in a minute, and one of them is improve, and we've had really focused discussions on how we can drive improvement better without becoming the improvement agency. And there is a real conflict between a regulator being a regulator making judgments about services and giving them direct advice about how to improve. And we must be very careful we don't get on the wrong side of that conflict. So that's a very important point. And and I think it is important. People often will say to us, look, you spend your time telling people they've got problems, but you never tell them how to sort them out. And that's true, and that is true, because there is an intrinsic conflict between us giving people the answers. We're here to ask the questions and make the challenges. But what we want to do as a regulator is make sure that people who are challenged can find the answers from somewhere authoritative and effective in the system. Now, that won't be us, but we can signpost them in the right direction, and I hope that's where we can get to.
Thanks, Ted. And then a question about how we understand culture and openness if we're not seeing it for ourselves.
I'm not quite sure I understand what's behind that. If we're not seeing it for ourselves, just let me out the words in more detail, Sarah, just so I can understand quite behind the question.
So the question is, how do you understand culture openness if you do not see for yourselves? So I think this is a question about how we look at that if we're not going onto site and if we're not doing on-site inspections.
Oh, I see. OK, fine. So when in a few minutes time, I'll be talking about smart regulation, and smart regulation is understanding the risks in systems. And one of the things that we are challenging ourselves to do is understand culture much better. For instance, I was talking to Henrietta Hughes, the National Freedom Speak Up Guardian, last week, and she's produced an assessment of freedom speak up scores across all trusts in the country, and that is a measure of the speak up culture in those trusts. Well, freedom to speak up is so central to a healthy culture in an organisation. That may be a very important measure. We will certainly test it out. Other issues such as the staff survey, such as the RES scores, for instance, and we know that the RES scores are a strong reflection of the culture in organisations. So there are lots of aspects of culture that we can look at to make sure that the trusts have got the right culture. But I suppose one of the things I would like to say to trusts is, what are you doing to assess your culture? What have you done to assess your culture? And what confidence do you have that you have the right, open, honest, transparent culture in your organisation? Can you demonstrate to us you've found that out, and you can demonstrate that to us? Because again, this is a conversation where we want to challenge trusts, because sometimes they're going to have better ideas how to follow this up than we do, but we want to challenge them to explore those ideas.
Thanks, Ted. And I think probably a final question for this section. It looks like we've got a few hospices on the webinar, which is great. And there's a few questions around kind of pointing out that they are, a lot of them are charitably driven and charitably funded. And as a charity, their inspection status can have an impact on their ability to fundraise, which is vital at this time. So some of them saying that they've been through significant transformational change, which might change their rating, and other questions around how the transitional approach and the change to how we manage and monitor kind of balances with their need to fundraise, and how their ratings linked to that.
I'm sure there'll be lots of reasons. Hospices, you're talking about fundraising. There'll be other providers we have that have got business interests in their rating. There are others who feel it affects their external reputation. Now, we are very conscious of that. We realise how important ratings are as an organisation, and I think we're as frustrated as anyone that COVID has kind of really got in the way of doing that. As we go forward, we want to produce much more up-to-date ratings, and I'll come back to that under the strategy in a few minutes' time. And as I've said to you already, I think we recognise the issue. We are very focused on it in terms of what we can do. It is important going forward that we can get people's ratings as up to date as possible, and we're very mindful of that. It's not going to be easy, though, because during a COVID pandemic, we cannot do big comprehensive inspections. That would, I think, be unreasonable in the light of the pressures on the service and the risks that would entail. But we need to find another way of providing reliable, rigorous, credible ratings, and we are focusing on that at the moment. So we are very much focusing on that going forward, and we'll come forward with plans for that going forward. What we don't want to do is in any way undermine the value of the ratings by not keeping them as rigorous as they have been in the past. So we want to make sure that future ratings are as valuable as past ratings. They may not be based on comprehensive inspections in the way they have in the past, but we want them to be just as valuable and just as valued.
Great, thanks Ted. So we do have more questions, but I think if you want to move on to the next part of the presentation, we've got a bit more time at the end for questions.
And I do think I ought to move on. So we will have time at the end for more questions, everyone. And I know those questions are really good, so thank you for them, and thank you for your thoughts there. So the strategy. So as I say, our draft strategy was released in September, end of September. It's there available if you want to have a look at it, and there's opportunity for feedback on it. I'm going to give you some of the headlines from it and some of the sense of it from my perspective. But having said that, please do go and have a look at the whole document. It is not a long document, and hopefully it'll be a good read. But I hope equally you'll have suggestions you can make for how we can make it better, because we want this strategy to really drive us forward for the next 5 years or so as a regulator. So as I've said already, we are changing because the world is changing, and we have learned a lot over the last few years, both from our regulatory activity, but also from our interaction with different parts of the system. So we recognise that in order to stay relevant and to drive our purpose forward, we need to change. And that is what's behind our new strategy. Next slide, please. So our strategy has 4 themes. They're there at the top: people, smart, safe, and improve. Now, they'll probably have slightly different titles by the time the final strategy comes out. Those are just the short titles at the moment. The first one on this slide is people. And a couple of points I want to make is that we really feel that we need to make people using services at the real centre of our strategy going forward. And there's several aspects to that which are really important. We need to be better at listening to people, listening to their views, and looking at services through their eyes. And remember, we rate services and we report on services for the benefit of people using services. And that's really important. And we need to keep that really central to what we talk about. People have told us, and I talked about the provider collaboration reviews and local system reviews a few minutes ago, but people have told us that often the things they may find most difficult in services is, 1, accessing the services they need, and 2, falling through the gaps between different providers as they go through a pathway of care. So we want to have a look at services through the eyes of people, looking at pathways of care and how the system serves people, as much as how individual providers provide quality of care once people are inside the provider's space. So seeing things through people's eyes means, I think, a more system view of people's experience of care, and that's going to have to inform how we go forward. I've touched on that already in our transitional approach, and we will be driving that forward more going forward. Another important aspect is that people from different parts of society and from different backgrounds experience care in different ways. And so we want to be more vocal in assessing people's experience of inequalities in care. And I think it is increasingly clear that you cannot have high quality care if you are not tackling inequalities of care, to make sure that everyone has the best chance of accessing the care they need and has the best chance of the best outcome for them as an individual. So we will be building inequalities of care and how providers and systems assess those and manage those, how they focus on the care of their individual population and the needs of their population, to be much more central in our assessments going forward. There'll be other aspects of this too. As I say, we want to up-to-date our ratings so they're more frequent, because people have told us they want to know what the quality of service it providers is now, not what it was several months or several years ago. They want to know what it is now. So we need to make sure our ratings are up to date. And also our reports, I think, have often felt as though they're driven by the needs of us as a regulator or you as a provider, rather than by the needs of people who are looking at services and wanting to make judgments about which services they access. So what our reports become much more, if you like, targeted on people who use services rather than the professionals who provide them. So the reports are probably going to change. They probably won't be documents so much as web-based reports, and there'll probably be more summary reports highlighting the aspects of care from people's perspectives. So they'll be backed up by all the detailed evidence, but the evidence will not be there in the detailed report. Next slide, please. So next aspect of care is what we're calling SMART, which means smart regulation, I suppose. And what we're saying here is, how do we become a modern regulator? We've had a very paper-driven system up to now. We, of course, need to digitize our systems. And one of the things we've been doing with the emergency support framework and our transitional regulatory approach is to build that on a digital platform rather than a paper-based platform. And going forward, we're going to build on that digital platform. So it'll become a very digitally based regulator. Now, that helps in many ways. One, it helps internally within our system to drive productivity and consistency between the systems. So it's important in terms of that internal quality control as well. But equally, it enables us to look at intelligence and data in different ways. And we want to explore the way we use intelligence and data to drive our assessment of risk and our regulatory response. We recognise that our data requests to providers are often very burdensome. We've heard this, and we want to reduce our data requests to providers to only ask for data from providers where it's absolutely necessary. Ideally, we should be accessing all our data from externally available sources, from national data sets, etc. And where those data sets don't exist, we need to be making the case for those data sets to be established. One of the things that's been good during COVID is there's been much more transparency of data at a national level, with the different arm's length bodies sharing data much more freely than perhaps they have in the past. That's something we want to build on. We want to make that positive going forward. One of the things we've discussed with some providers, which again we want to build on, is since providers look at the data internally within their organisation, can we access that data directly by accessing their data systems, rather than having to go through a transactional approach where we ask them to provide data, they have to fill out a spreadsheet and send it to us? Why can we not look straight at their data as a regulator, so we can see what you can see, and we can understand the challenges you're facing from your perspective, but also see how you're addressing them? And again, that will drive, I think, a much better discussion between you and us. The other aspect of SMART is this issue about ratings and assessments. We want to make these ratings and assessments much more up to date, and we're kind of using the shorthand of how do we create real-time ratings. Now, they'll never be truly real-time, but how can we make sure that the ratings are never more than a few months old? Now, that cannot be by driving ratings by comprehensive inspections. It has to be by a different approach. And we are actively exploring that approach, as I say, in the short term, to try and meet some of your expectations for early refreshment of your ratings, which we're keen about, but also in the long term going forward. So that we will be going through a system whereby people's ratings will be current all the time. And I think that's really going to be important going forward. So we want to become a smarter regulator, and that's one of our central themes. Next slide, please. Safety. Now, safety is one of these aspects that we haven't really cracked, and I've said publicly that I don't think we've turned the corner on safety in the way we should have done. And that is not a criticism of anyone, it's just a recognition that we haven't got ourselves into the position where we really are approaching safety in the right way. And we as a regulator explored safety 18 months ago when we published a report on never events, and the key finding of that report is that if we're going to reduce adverse incidents, excuse me, in terms of never events, we first of all have to address the safety culture. It's not a process-driven thing. Process only works if the culture is right. And so going forward in terms of safety, we want to be part of driving the best possible safety culture across the whole system, across providers. That is a real challenge, and I don't think it's going to be easy, but unless we are pushing towards it, we'll never get there. And so we want to get people on our side. We want to build a coalition of safety, focusing on safety culture, and accepting the fact that errors do occur. Of course they occur, that avoidable harm is bound to occur, but while it is inevitable, we should never get into the position where we are behaving as though it's acceptable. Whenever there's avoidable harm, we should be striving to reduce it wherever we can. And that must mean a different approach. Some of it is about expertise on safety. And I suppose that one of the problems we have is that safety expertise is often assumed, but we don't have a real sense about what safety expertise is, as other safety-driven industries do. So what we want to do is encourage a much stronger focus on safety expertise, both within providers, but also within ourselves, the CQC, because we recognise we have a lot to learn as well. We also want to involve patients and service users in safety much more actively. Not just, if they make a complaint or if there's a serious incident, but how can we make them real partners in safety so they're not passive recipients of safety, but active partners in safety. So it's a big change in culture we're looking for in terms of safety, and we want to be part of that. We know we can't do it by ourselves. We need a coalition of partners to drive this through. I hope you'll join us on that. I think it really could make a phenomenal difference if we can get it right. Next slide, please. So the final issue is improve. We've touched on this already as we've been talking through these slides. And we recognise, and lots of providers have said this to us, you tell us what's wrong, but you don't tell us how to address the problem. We work very closely, of course, with other bodies such as NHS Improvement to help people get the support they need. We want to make that much more active going forward, and not just within NHS providers, but across all providers in health and social care, in the NHS and in independent services. So we want to make sure that all providers can access the improvement support they need, so that when we come in and find a risk and ask you to address it, we can follow that up with saying, well, this is the improvement support that is available to you. And we as a regulator are making sure we're on your side to make sure that improvement support is readily available when it's needed so people can drive improvements. We're talking about this in terms of an improvement alliance, Now that is never going to be the CQC giving you the answers. It's going to be the CQC helping you find the answers. And that is the fundamental difference. We are a regulator. We can't step over into being an improvement agency, but we recognise there is need for a really strong improvement side across all health and social care providers, and we are committed to working with others to make sure it is available, and we are actively looking for partners to work with us in this regard. So that's improvement. Next slide, please. So that is where we are now. We are consulting on our strategy, and I've given you some headlines from that. Please do look at the whole document. We are developing our transitional approach, and we're building up to the formal consultation on strategy in January of next year. As we go forward with the transitional approach, there will be iterations. It will change over the next few months. It is not fixed in stone now. We recognise it needs to change. We've talked about the ratings being an important area that we still need to explore, and we recognise that. We're also going to learn as we develop the transitional approach, because that learning will help inform how we implement our strategy going forward from next summer onwards. Next slide, please. So the future, as I say, consultation will begin next January. Now, everything is not going to change overnight. It is actually surprising how the pandemic has meant a lot has changed very quickly, and I think we've all surprised ourselves. I've certainly seen some services that have really changed the way they provide care quite dramatically, quite quickly in response to the pandemic. So there's been a lot of really good work in response to the pandemic. We've changed the way we operate in response to the pandemic, again, very quickly. Have surprised ourselves in that regard. But a strategy is a long-term aim. We will not deliver this all overnight, but we want to make sure that as we go forward, we have really strong implementation plans and strong partnerships in place to deliver our strategy over the next 5 years or so. Next slide, please, which I think is the questions again. Okay, right, fine. So that is all the slides I'm going to talk to in terms of our transitional approach and strategy. So back over to you to ask any questions or make any comments. Sarah, do you want to lead the way?
Yes, thanks, Ted. So just to start by saying that we've had lots of comments and lots of questions. So if we don't get to all of them, which we might not do, just to be assured that we're taking everything in and we're feeding it into our teams to inform how we develop the strategy. So your points they are being logged and looked at. So a question around the Improvement Alliance and whether you could provide any further insight into how that type of support could work and what we might think of that. I think particularly in the context of maybe NHS and independent health providers?
Okay, well that's a good challenge. Have a look at the strategy, and that gives us some more pointers towards it. I think what we want to do is to identify, our assessments of trust and our work with trust will help us identify the challenges they're facing. What we want to do is to work with other third parties, be it NHS Improvement. Of course, NHS Improvement is going to be central to this, but perhaps other third parties as well, such as independent bodies, such as different trusts. So, I mean, one of the really positive things that have come out of some of our reports is where we found really good practice in one trust, they've become really helpful in supporting other trusts follow up and learn from them. And we want to do more of that. So what we want to do is, by identifying the issues, we want to work with these other providers to help them find their solutions. And so when we find an issue in a trust, say it's a cultural issue, we're talking about culture, and culture is so important in driving quality. If a trust has a problem with a cultural issue, we'll say, well, actually, we know an organisation that has done a lot of work successfully with trust to address this. Let me put you in touch with them. Or we know a trust that has addressed a similar issue successfully. Why don't you put in touch with them? And I suppose it's that kind of alliance, so that we know the good work going on out there, we know what is available, and we can help people find it. That is going to be, I think, what we want to do. And so driving quality is not going to be, driving improvement is not going to be just purely by us doing things. It is by us finding the help out there. And we are actively looking for partners, and be they other providers, be they third party organisations. And this is not just in the NHS, I should say, it is in independent healthcare as well. So we are very keen to find improvement third parties and supports across the whole health and social care system. In truth, the NHS trusts have had NHS Improvement for a while. Now we can build on that. But some other parts of the system have not had really any improvement arm at all. And we want to see improvement supporting providers across the whole health and care system.
Thanks, Ted. A few comments and questions around the kind of information and data sharing and the data that we might use ourselves. So particularly independent healthcare providers don't submit to several data sets, for example, national audits, and some of them are set up for, some of the national data sets are set up for large NHS trusts and aren't appropriate for or accessible necessarily for small independent healthcare. So when it comes to independent providers or those smaller providers, what digital data will be used, and how will the approach be adapted for some of the smaller providers so that providers aren't at a disadvantage?
Yeah, a good point, and I think we've already been for a while now a strong advocate that these data sets should be available to all to enter data into, not kind of, if you like, kept for a privileged few. So things like the NHS national audits, we've been encouraging independent healthcare, but also the national audits themselves to come together so that the NHS audits can include independent healthcare. And remember, a lot of independent hospitals are treating NHS patients. It's not as though they're from outside the NHS. So a kind of real sense of we've all got to work on this together, because this is everyone's interest to make these data sets really effective in understanding risk. I think for those sectors that don't have established data sets, then we want to work with them to how those data sets can be established. How can this sector make sure it's got the data it's necessary to assess risk? And this is a dynamic process. We learn about it over time, but we want to engage in that. So it's not a matter of penalising people. What we want to do is go to, say, a sector and say, you don't really have any good national data sets. How can we work with you to make sure that data set is set up? And how can we make sure it's the right data set? Because it's so easy to collect information just for the sake of it. What we want to do is collect the information that really helps us make the right decisions in assessment of risk. So we want to become, and this ties in, of course, to the improvement side, we want to become an enabler, a supporter, a facilitator of people getting the right data. And of course, that data is valuable to them. Most importantly, valuable to them. It also helps us understand what's going on. So I totally accept there are sectors across health and social care that do not have much in the way of national data, and that, of course, has been made very clear by the COVID pandemic, where we've been looking at data. While some parts of the system are awash with data, other parts of the system have got very little. We want to try and make sure that, if you like, there is any quality of the use of data across all of health and social care.
Thank you. And I suppose slightly building on that question, how will providers' quality and safety information be shared between regulators to ease the burden on all providers? And will it be clear in the new strategy what information is being shared and when?
Well, I'm very much committed to transparency. So the answer is yes. We want to be clear. We don't want anyone to. You don't want anyone to be having conversations about quality without including everyone. So if you're having a conversation about quality, you should be including us. If we're having a conversation about quality in your provider, we want to be including you, and we want to try and get to that kind of trusting, open, transparent relationship. And likewise, if I'm talking to other parts of the system about quality in a provider, we want the provider to be aware of that. We don't want the provider to, if you like, not know what our concerns are, because, you know, ultimately it's the provider who's got to address those concerns. In terms of data, yes, I do think there is a problem though, and that is within the NHS, as I say, to wash with data. There's too much data, and there's a lack of rigor about assessing what data is the data we should all be looking at. And one of the things I've been trying to do on the National Quality Board is working with the other arm's length bodies to try and make sure we have an agreed assessment of what quality in individual providers, but also in systems is, to make sure that we're all looking at the same thing. Now, that's a dynamic process, and there isn't a kind of fixed point where we've defined the data that we need to look at quality in, say, a system. It will be dynamic, it will change over time. But we ought to have a common understanding of what the most important elements are and make sure we're assessing them. One of the things that I think we will, as CQC, become more focused on is system data as much as single provider data. You know, and I think if there are risks identified in the system from system data, then we will come to the providers within that system and say, look, we've seen these risks in your system. How are you involved in addressing them and resolving them? It won't necessarily be what you can do just yourself. It may be how you're forming collaborations with other parts of the system to make sure they're addressed. As I say, we want to look at the risks through the eyes of people using services, not just through the eyes of providers.
Thank you, Ted. And just moving to a bit more of a, I suppose, an operational question, but one that's got the most likes, whether there's still a requirement to complete the PIR prior to a visit, and linked to that, will it be modified to be less onerous?
Well, we haven't issued any of the kind of comprehensive inspection PIRs for quite a while now, so they are a feature of our comprehensive inspections, and so we're not going back to comprehensive inspections in that way. As I say, we need to find ways of rating, and we may need to do some data requests in order to form our rating process. That's an open question. I don't know as yet, but that may be so. We're not going back to the comprehensive inspection PIRs though. I can't say at this stage there will be no PIRs. During our inspections, our risk-based inspections that we're doing at the moment, they are not usually preceded by a PIR. They're usually unannounced on the basis of risk. We may ask for data after the inspection just to make sure we've got a full view of the evidence. So they're much less burdensome, which is one of the reasons why we're focusing on them at the moment rather than the comprehensive approach. But I think we've heard loud and clear from many of you how burdensome some of the PIRs have been, and we do want to move on from that. So we are doing absolutely our utmost to make sure we don't go back to that position. But it does mean that the kind of big reports that we produce in terms of the evidence appendices for NHS trusts will not be published in the same way going forward, because a lot of that was driven by the PIR information. We need to look at the data we have already and make sure that we're using that effectively to assess risk, and only ask for additional data where necessary. And as I say, if one of the things we could do, and this is not going to be easy to deliver, is to access your systems directly, then we don't need any kind of transactional intervention with you at all. We don't have to ask you for information. We can monitor it on an ongoing basis. And I think that would be where we would like to get to if we're going to get to this real-time assessment of quality going forward. That's not going to happen overnight, but I think it would be a great advantage if we could get to that. And certainly with big NHS trusts with sophisticated data systems, that should be achievable.
Thank you. And then a question about systems. So great that we're looking at the patient pathway and system, but there is an inherent problem is you rate organisations, not systems, where a good rating does not really relate to a good system worker, as it forces organisations to look in, not out. How do you plan to address this?
Well, I think our ratings going forward, and again, this is for the new strategy, are likely to reflect system interactions much more. And so, can you have an outstanding provider in a poor system? We'll probably find some way of building into our assessment the fact that you're working in a poor system, you're not showing effective system leadership, therefore that reflects on the provider rating. So I think we are conscious of that, and that's one of the things we need to do. We don't want a kind of sudden change in ratings, though. The ratings have got to, if you like, have a kind of credibility based on previous ratings. So this will be a gradual process, but I think the ratings are increasingly going to reflect system working as much as other aspects of care.
Thank you. And a question around patient experience data. So we say we'll be using more patient experience data. How will we be gathering that, or will we be asking trusts to share data already gathered?
I think if I could just express one of my frustrations is that one of the things we've seen not very much of in trust inspections is a collection of patient experience data beyond friends and family, and there seems to be kind of focus on that as a core. And I think one of the things we want to challenge trust to do is how are you assessing patient experience in more detail than perhaps just the kind of the contractual requirement to do friends and family. So I think that will be important going forward. We've developed a new system which was launched this year called Give Feedback on Care, which is a web-based system that people can, on their phones or their tablets as well as on their computer, can give feedback on their care from different providers. That has really gone down very well, and we've seen a big surge in the amount of patient and user feedback we're getting on that, which is really good. So we will explore ways of us getting direct feedback of patients. We will explore ways of developing focus groups, perhaps virtual focus groups, but focus groups to actually understand what patients' experience of systems is. But equally, I think we want to challenge providers about how are you getting that patient feedback in a way that makes a real difference to care.
Thank you. And I think we might have time for one last question. Will CQC be returning to the previous inspection strategy or approach, or do we see this as your permanent approach going forward with or without COVID?
Well, I think our transitional approach is our approach for the next few months. The permanent approach beyond that, which will build on learning from the transitional approach, so it's going to be a continuum with it, will be implemented next year. We're not going back to our previous approach its full form. I mean, clearly we're going to be living with COVID for the next 6 months at the very least. So there's not going to be an opportunity to go back to that before we launch our next strategy. And our next strategy is forward looking, not backward looking. So I think the kind of big comprehensive set piece inspections are probably, by force of circumstance with the pandemic, not going to return at this point. We will have a new system based upon what we've learnt during the pandemic and our strategy from next summer onwards. As I say, our strategy is the first point of that. We'll be consulting on that in January, so please do feedback on that. And then the implementation of our strategy, which will deliver the reality on the ground, will come later in the year. Sarah, we're just about out of time, so can I just go to the last slide here, which is about getting involved. Now, I did say that we're keen that you should be involved in feeding back on what you've heard today, on our strategy, our draft strategy, and on your experience of our transitional regulatory approach. This is very much something we are learning from, so don't feel that we're not receptive to your feedback. We are very keen on your feedback. We recognise that this is an iterative process going forward, so please do feedback. This is how you can get involved. I think Sarah, I'm right, the draft strategy was published on Citizen Lab, wasn't it? So people want to go there to actually look at the draft strategy. Of course, there'll be lots in bulletins and blogs. So please do look at that. That's all available, and you'll get it headlined on the Twitter account, etc. So please do stay in touch with us and do give us your feedback going forward. We are just coming up to 11 o'clock, so I want to thank you for joining us today. I hope you found it helpful. Thank you for the really challenging but interesting questions, and we will look at all the ones we haven't been able to answer and take that comment and feedback and see if we can provide answers in different ways. So thank you very much, everyone.